Good afternoon, everyone. My name is Lucy Wee, and today I will be presenting the clinical case for patient Elsie, a 32-year-old female archaeologist who developed a complex combination of infectious, respiratory, gastrointestinal, and nutritional complications requiring extensive medical and nutrition management. I'll begin by summarizing the patient's clinical situation, then explaining how her environmental exposure as an archaeologist directly contributed to the diseases she developed. Next, I will review her relevant medical history, analyze the organ systems involved, estimate her nutritional needs, provide her enteral nutritional prescription, and conclude with a PES statement and discharge nutritional education. The patient presented with a 3-month history of abdominal distension, nausea, reduced appetite, and a 16-pound unintentional weight loss. In the days before her hospitalization, she developed acute symptoms including fever, cough, vomiting, diarrhea, night sweats, a rash, and worsening abdominal pain. Imaging revealed massively dilated, non-perisystolic, small bowel loops containing moving tubular structures consistent with Ascaris lumbricoides. She was diagnosed with a mechanical small bowel obstruction caused by ascariasis. In surgery, her entire duodenum and 100 centimeters of ischemic proximal jejunum were removed. She required mechanical ventilation and subsequently developed DIC and a stage 3 pressure injury. She also met criteria for severe protein calorie malnutrition. To understand how the patient developed multiple infections, it's important to consider her occupation. She had spent the past year excavating deep cave systems in the Yucatan Peninsula. The environment exposes individuals to several pathogens. The caves contaminated with rodent droppings are a known source of hantavirus pulmonary syndrome. This matches her respiratory failure, pulmonary edema, and hypotension. The dusty excavation sites in desert-like environments can aerosolize coccidioides fungal spores, causing valley fever. Her fever, cough, night sweats, and rash align with this condition. The handling of soil during excavation increases exposure to Ascaris eggs. Heavy worm burden explains her obstructive symptoms and the roundworms found intraoperatively. Her clinical picture perfectly fits the infectious risks of cave archaeology in endemic regions. The patient's medical history significantly influenced her response to infection and surgery. The patient has Crohn's disease with a prior 79-centimeter terminal ileum resection, placing her at baseline risk of malabsorption. She also has hypothyroidism, chronic vitamin D and B12 deficiencies, a vegan diet, ADHD, insomnia, and a history of traumatic pancreatitis. These factors increased her susceptibility to nutrient depletion and worsened her malnutrition during this acute episode. The gastrointestinal system was most severely affected. Her bowel obstruction led to ischemia requiring removal of the duodenum and part of the jejunum. Because she had already lost part of her terminal ileum earlier in life, she is now at high risk for short bowel syndrome. The pulmonary system was compromised due to the hantavirus pulmonary syndrome, contributing to respiratory failure. The hematologic system was also impacted. She developed a disseminated intravascular coagulation. Her stage 3 coccyx pressure injury increased her protein and micronutrient requirements. The patient weighed 53.6 kilograms at 175 centimeters tall, yielding a BMI of 17.4. This is consistent with underweight status. She experienced a 12% weight loss over 3 months, indicating severe malnutrition. The biochemical markers, including an albumin of 1.8, vitamin D of 12, and anemia with hemoglobin of 10.9. The physical exam revealed a loss of muscle and fat stores, as well as a stage 3 pressure injury. Collectively, these findings confirm severe protein calorie malnutrition. Based on the patient's weight and clinical condition, her estimated needs are of 1,600 to about 1,875 calories per day, 80 to 107 grams of protein per day, and approximately 1,600 to 1,875 milliliters of fluid per day. These needs are elevated due to the infection, surgery, malabsorption, wound healing, and hypermetabolic stress. Given the patient's significant loss of absorptive surface, the most appropriate formula is Vital 1.5. This peptide-based formula promotes better absorption, provides MCTs to provide fat tolerance, and delivers a higher caloric density, which is advantageous in patients with limited bowel length. Vital 1.5 is frequently recommended for patients with short bowel syndrome or malabsorptive conditions. The patient's resections have major nutritional consequences. Loss of the duodenum reduces iron, calcium, magnesium, and folate absorption. Loss of 100 centimeters of the jejunum reduces carbohydrate, protein, and fat absorption, contributing to diarrhea and electrolyte losses. Loss of the terminal ileum eliminates B12 absorption and bile acid recycling, leading to fat malabsorption and increasing her risk of oxalate kidney stones. Together, these resections place her at a high risk for short bowel syndrome and chronic malabsorption of nutritional content. The patient will have to eat small and frequent meals following a high-calorie, high-protein vegan diet. The patient can use MCT oils for additional fat calories. The patient is to avoid drinking fluids with meals to slow transit and use oral rehydration solutions rather than plain water. The patient will require supplementation of B12, vitamin D, calcium, fat-soluble vitamins, iron, zinc, and magnesium. The patient should monitor stool volume, hydration status, and symptoms of malabsorption. In this clinical study, we are able to observe the intricate combination of environmental infections, Crohn's disease history, massive bowel resection, and severe malnutrition. The patient's enteral nutrition plan using Vital 1.5 adequately meets her needs during recovery, while long nutrition management is essential due to her increased risk of short bowel syndrome.